Hello, everybody. I will, during this lecture, I will present assessment of male infertility. And the assessment of male infertility should be properly done. And I will tell you why it should be properly done and when it should be done and how, in my opinion, it has to be done. Actually, it's important, as Dr. Ashraf said, because it represents about 50% exactly of couple infertility causes. So you cannot neglect or miss male infertility evaluation. Also, it's important to assess it because you can detect treatable abnormalities, and you can, if you decide to do ICSI, you can, after assessment, decide what is appropriate, IVF or ICSI, or if you are going to do IUI. And you can also, after assessment, advise for special or extra technique during ICSI. And many genetic conditions can be associated with male infertility, so you need to know them, as they can be transmitted to offspring with assisted reproduction or results in a failure of the technique. Also, it's the occasion that you can sometimes find life-threatening problems associated with infertility. Regarding the second question, when to evaluate male infertility, actually, as agreed with the female infertility, you have to wait for 1 year, unless the couple questions the male partner's fertility potential, or there is a female infertility risk factors, including advanced female age over 35, or there is a male infertility risk factor as a history of cryptorchidism or delayed puberty, or male pelvic surgeries, or chemo or radiotherapy. Regarding the third question, how, and this is the main topic of today, so it should include the evaluation, complete medical and reproductive history, followed by physical examination by a specialist in male reproduction or by gynecologists who know how to examine a male. And you should request at least 2 semen analysis separated by a period of 1 month. After that, you can decide if you need additional semen analysis or endocrine evaluation, or you need to do a post-ejaculatory urine analysis, ultrasonography, specialized test, and genetic screening. So the start is always by the history. A full history is important. Coital frequency and timing, childhood illness and development, systemic medical illness, prior surgeries, sexual history, gonadal toxins. You need to review all medications that are taken by the patient, family reproductive history, and any previous history of assisted conception, and importantly, wife age and condition. While a man may have a previous fertility, this does not include the possibility of male infertility, and you need to check for male infertility, even he had previously children. Smoking is very important because smoking interferes in male infertility by various mechanisms: reactive oxygen species, exogenous metabolites, and hormonal deficiency. Medications that may negatively affect male fertility may be antibiotics or antihypertensive, chemotherapeutic agents, hormones, or miscellaneous agents. But these are common drugs that patients may use it. Allopurinol, cimetidine, colchicine, cyclosporin, sulfasalazine, antidepressants, psychotropic agents. So you need to have a full list of any medications that he is taking. It's not surprising that genetic causes are here and infertility may run in families. After a full history, you need to do a physical examination. You start by general examination, and you need to observe the secondary sexual characters. This is a case of hypogonadism. You can just by inspecting the patient, when you see that there is no bird, no enough hair, breast development, female hair, pattern of hair, small size, long legs. So just by looking at the patient, you can diagnose hypogonadism. I usually spot them when they are entering just at the door of the clinic. I know the diagnosis before he starts to speak even. After that comes the door of genital examination. After inspection, you need to palpate the testis. The testis is usually smooth and rubbery and mobile, ovoid in shape and free from nodules. You can use an orchidimeter to settle the size of the testis, which is about 15 to 20, maximum 25, below which it shows that there is a hyperfunction in the testis. After that, you palpate the epididymis for any abnormality or enlargement or absence. Finally, you roll the cord to detect any varicocele and to palpate the vas deferens. Actually, the diagnosis of absent vas is a clinical diagnosis. You don't have to miss it by clinical examination. Also, varicocele can be diagnosed just by inspection or by palpation if it is a secondary degree. After that, you finish by a PR examination for the prostate and seminal vesicles for any abnormality. After clinical examination, you have to ask for a semen analysis, which is the most important diagnostic tool. Generally, you ask for an abstinence period of 3 to 4 days maximum. After the semen analysis, you have got the result. Either you are satisfied with the normal semen analysis, or you need to repeat it after 1 month to have a confirmation. And if the semen is below certain threshold, you may think about a full endocrine evaluation. Actually, hormonal abnormalities are well recognized, do not come in a cause of male infertility. And some doctors believe that you have to do it for every patient. But actually, I believe that endocrine evaluation, and many physicians and scientists believe it has to be done only for semen analysis where the sperm concentration is less than 10 million, or if about that, but patient has impaired sexual function. Mainly when you ask for hormones, you can start, you have to do FSH, is obligatory. The second most important after FSH is testosterone. If you do these two tests and they are normal, it's okay. But if there is any abnormalities in testosterone and FSH, you need to do total and free testosterone as well as LH and prolactin. From hormones, you can reach this diagnosis. In hyperprolactinemia patient, you have high prolactin and all the 3 hormones are below normal. In hypogonadotrophic hypogonadism, the first 3 are low and the prolactin is normal. In hypergonadotrophic hypogonadism, FSH and LH elevated and testosterone is low. In impaired spermatogenesis, you have a high FSH and the other hormones are normal. If the patient is taking androgen, and this we see very common either in patients doing gym and bodybuilding, or either by some doctors who prescribe wrongly androgens, thinking they are helping the patient, but they result in a drop of FSH and LH, and this is very bad for spermatogenesis. After that, you can ask for a scrotal ultrasound if on physical examination you was unable to palpate the testis properly, or if you are suspecting any scrotal mass, or if you are unable to palpate the testis because a small scrotal sac or high testis in the upper scrotum. You may also ask for a trans-rectal ultrasound if you suspect a high obstruction in the level of epididymis or vas deferens. Trans-rectal is helping in diagnosing also patient of congenital bilateral absent vas deferens, because seminal vesicles may be absent unilaterally or bilaterally in such patients. TT or MRI pituitary can be asked for if you suspect hyperprolactinemia or any pituitary lesion. Regarding genetic examination, karyotype is the most important and is the test that you have to start with especially that chromosomal abnormalities account for 6% of all male infertility. And this percentage increase with increased spermatogenic impairment, such as severe oligo and non-obstructive azoospermia. The importance is that parental transmission of chromosome defects can result in pregnancy loss and birth defects and male infertility and other genomic syndrome. So please do it when you have a patient with below 5 million. Klinefelter is syndrome 47XXY is the most common human sex chromosome disorder that we have, with a prevalence of 1 in 500 or in 1,000 males. And it accounts for 11% of azoospermic cancer. So Klinefelter is very, very common and underdiagnosed in our population. The most common balanced transstructural chromosomal rearrangement is Robertsonian translocation, with the frequency of 1 in 1,000 in newborns. Also very, very, very frequent. And it's more frequent among the infertile couples, especially in oligozoospermic men, than in healthy population. So don't miss it, because this translocation may result in missed abortion or failure in ICSI, and these patients will need PGD. And the first case report of a successful NGS for a translocation carrier was in since 5 years, and it is a standard nowadays in such patients to do a PGT with NGS. Y-chromosome microdeletion are quite present in 13% of men with non-obstructive azoospermia or severe oligozoospermia have such deletions. And these deletions are detected using PCR, and the detection of Y chromosome has both prognostic and ethical significance. From a prognostic point of view, when you have a deletion in A or B region, you are quite sure that you are not going to find any sperm after testicular sperm extraction, while if you have a C deletion, you are expecting to have sperm up to 70 or 80% of men will have sperm in their testes. The other aspect of this test is that you can counsel the patient that if they have any male offspring, he will also suffer from this deletion and the consequence of deletion. So he may choose perhaps to have a girl. I need to speak about semen analysis, because semen analysis is very important in evaluation of male infertility. And I need to speak about the standard approach that we have. Actually, today you have robust and reliable standardized laboratory methods available for all andrology laboratories. And I'm inviting all practitioners, all lab in Egypt to adopt the WHO manual, so that we can read all the same, interpret the same thing, and communicate with all parts of the world, especially that this manual can be downloaded easily from the internet, and it focuses on standardization and quality control of semen analysis, and all the methods described are amenable for use in any third world country in the world. Semen analysis have evolved all over the years. So from a volume of 2 milliliter, now we are accepting 1.5 milli. Criteria are becoming less stringent than before. Sperm count was between 20 and 200 million. Now we can accept just 15 million. And total sperm count 39 instead of 40 or more. Motility 40% is quite acceptable, provided that we have A and B motility of 32%. That was 50% before. Vitality is 58% instead of 75 in the last manuals. And morphology, by the strict criteria nowadays, are accepted to be only 4% abnormality. So these are the parameters for 2010. Till now, there is no another issue. So, but these are the figures you have to notice and you have to work with. It's very important the patient do two semen analysis because there is a lot of variation in semen count from time to time. So to have a definite picture of what is the semen analysis about, you have to do it at least in 2 occasions. Concerning the sperm vitality testing, it's an integral part of semen analysis nowadays, and it's very important to detect viability of non-motile sperm through this test. It's a risk assessment during semen analysis and can be carried either in the analysis or after that. And you have to do it in samples with less than 50% motile sperms to check on the accuracy of motility assessment. And the lab has to do it if it has a motility less than 5 to 10% to distinguish between necrospermia and structural sperm defect like primary ciliary dyskinesia. So it can be done by stain where damaged sperm membrane will take the stain and normal sperm will not take the stain. And if you don't wish to use any stain, you can do the hyposmotic swelling test where living sperms will curve. Both are good for necrospermia diagnosis. It's true that it is a rare condition affecting only 0.5% of infertile men, but in some patients you can use the ejaculated sperm for ICSI, but in many cases you will be obliged to use testicular sperm because ejaculated sperm may be immotile or dead. So it's recommended to do testicular sperm extraction. In our experience, 50% of these patients have motile sperm in their testes, and the other 50% have a vitality of 90%. The second part, which is very important also as a part of integral part of semen analysis, is the morphology evaluation. And sperm shape is very, very indicative of sperm fertilizing ability, the normal fertilizing ability. As you have seen, compared to other species, human beings have a very little range of normal sperm. And this little range will be associated with a fertility decline if it decreased above it. But to do a proper sperm morphology, you need that your lab do it with great skill and experience using morphological stains and not just by inspection. And here he can find many structural defects in the head or middle piece or the tail of the sperm. The strict criteria were provided in Tigerberg Institute by Menkveld and Kruger. It really predicts successful natural fertilization. And also it is a prognostic test for IVF. A long time ago in 1996, it was proved that with higher than 15% morphology normal sperm, the fertilization rate was 82%, with a pregnancy rate of 25%. But with lower than that, there is a drastic drop in fertilization to 37%, and no pregnancy were recorded in this study. So it's very important in IVF. In ICSI is not that much important because patients with poor morphology have similar fertilization and pregnancy to those with normal morphology. And using severely teratospermic have been also associated with a quite similar blastulation rate with ICSI. So these are facts. The reason is that most likely the embryologist is selecting individual sperm that appear morphologically normal by microscope from even the most important specimen, and the fertilization that occur is not representative of the whole sperm population within the entire sample. So if you are considering ICSI, sperm morphology is not that important, but take care because this can be right for polymorphic teratozospermia, but for not for monomorphic teratozospermia. Monomorphic teratozospermia is one kind of morphological abnormality with only one abnormality type predominate. So the most famous one is round head syndrome, the globosospermia, with the incidence of 0.1% of infertile men, where the acrosome cap is deficient, and that will not be possible that this sperm fertilize the oocyte. So you need to do ICSI, but unfortunately, if you don't have the sperm, there will be a low fertilization rate during ICSI. You need to do an activation of oocyte, either electrical, chemical, or mechanical, and here you are going to get a good result. Also, by the special thing, you can easily diagnose the short tail syndrome. This is very, very rare syndrome, but with very short tail. And also, these cases will need ICSI, but reports are very scanty regarding this syndrome. Also, another rare syndrome, but I have seen many cases here in Egypt because it's frequent in North Africa and in Mediterranean region, where the sperm has lost their head, and it's called pinpoint head. Actually, there is no, the head is broken, but sometimes you have some sperm with the head that you can inject, but you need to do a very big effort to find this sperm ejaculated. Usually you don't find, you need to do a testicular biopsy to find a good sperm, because most of the sperm lose their head while they transit in the epididymis. I have some pregnancies with such patient. It's a hell of work, but it deserves to do it. This is a very interesting case with the large head and multiple stills. I'm sure that most of us have seen such patients. And this is due to a homozygous mutation of urokinase gene, leading to a large-headed polyploid spermatozoa, and is a sure cause of infertility. Klaus Riedrich in France detected this mutation, and it was found to be very frequent in the Moroccan population. This is publication from Abdelmajid El-Walid, and it was also found very frequent in Algerian men and in Tunisian men. Here in Egypt, we can see this pathology in many Libyan patients coming to see us, and some of Egyptian living in Marsa Matruh and the north coast. I haven't seen in the Delta or inside only one patient in my life not belonging to the North Africa group. So this patient, if they can fertilize the ova, will result in 69 XX embryos and or Y, and will lead to an abortion. Sometimes, in very few occasions, you can find few spermatozoa which are normal, but before embarking in doing ICSI, you need to do a fish analysis to be sure that there are some haploid sperm. If you don't find any haploid sperm, please don't do ICSI, it will fail. And if you do ICSI, please do PGD if you have this possibility also. Traditional sperm analysis, in spite its importance in morphology in some special cases and vitality in some special cases, generally is of limited benefit because it is subjective. It has no real correlation with ICSI outcome. And in 15% of patients, male may have a normal semen analysis, and definite diagnosis of male infertility cannot be done on routine semen analysis. So semen analysis does not separate clearly between infertile and infertile men. This is because it was done on a 95% confidence interval. So you have 5% of patients that are below standards but still can be fertile, and also the one who are in the normal range can also be infertile. So value outside this norm just suggest a male and indicates the need of an additional clinical or laboratory evaluation of the patient or his wife. And a poor semen quality will point to a reduced chance of pregnancy. However, natural conception still may occur in some cases. And you can tell the patient that the more severe the semen defect, the lower will be the chances. Actually, it was observed that in 25% of patients having less than 5 million per ml, they have a pregnancy within a 2-year period. Also, men with high sperm quality are fertile even with low count. I'm recalling patients with hypogonadism when I gave them FSH and they start to give me a few sperm in their ejaculate. They can impregnate their wife. So you cannot rely only on semen analysis to tell the patient how things are going with him. Semen analysis is subabdominal test. Yes, it is suboptimal. It's just an indication. It's not an absolute test for fertility. And the reason is that sperm functions are not assessed by this test. And you cannot separate fertile from infertile. And there is a considerable overlap between values between fertile and infertile. So we need advanced sperm tests. Yes, we need. Because we cannot predict the fertility only by semen analysis, and some cases are unexplained. Normal semen analysis, we don't know why they are not becoming pregnant. The wife is normal, and a long history of fertility. Also, in cases of ICSI failure, the traditional or failed fertilization, the traditional semen analysis tell nothing about this matter. So we need advanced sperm test, the commonly used one, actually the classification of this test are the commonly used specialized test, which is being carried out in day-to-day practice, and the less commonly used one. The commonly used one are listed here. The most important from my point of view is sperm vitality and HOS and quantification of leukocyte and semen. That's why I put it in green. There are 2 other tests with controversy: the DNA integrity testing, the computer-aided sperm analysis, the CASA, and the last 3 tests, the biochemical test and the test of sperm cervical mucus interaction and test of anti-sperm antibody. They are obsolete nowadays. The less commonly used tests are ROS test, the acrosome reaction, human zonal the binding test, sperm penetration assay, and test and procedure to select sperm for ICSI. Actually, the DNA testing refers to a variety of assays utilized to evaluate the degree of sperm DNA fragmentation. This is important because studies of pregnancy by intercourse demonstrated that a statistically significant lower pregnancy rate in those patients with impaired DNA integrity. Yet many couples with DNA fragmentation are also fertile. As you can see from this table, 13% of fertile patients have DNA fragmentation, but infertile are 27% higher. This is was published in Fertility Sterility, and this was one of the first literature showing the importance of DNA denaturation. So these are the indication of DNA fragmentation if you wish to do the test. I would recommend, if you want to do it, it will be the first indication will be the couple with history of unsuccessful ART and couple with unexplained infertility, and especially couples with history of miscarriages, as there are data making a link between miscarriages and DNA fragmentation. Also, we can do it for men at higher risk of ROS, men with diabetes, men with history of drug abuse, men who have been treated for cancer and old age. Two main methods are currently available in Egypt, the tunnel test and the sperm chromatin dispersion test. The sperm chromatin dispersion test, halosperm, is the most commonly used. In non-fragmented DNA, the sperm will have such a halo. In fragmented, it will not have any halo, or in apoptotic. The advantage of this test is that it can be easily done, and many labs are doing it nowadays. You don't need any fluorescence microscope, any flow cytometry, so it's an easy test. It can differentiate between patients in the green zone, where the DNA fragmentation will be less than 15%, no apparent problem, and the red zone when it is more than 30%. Here we have probably a problem of DNA fragmentation. And in between, in the gray zone, here to judge what to do, you need to have a complete vision of the clinical picture of the male and his wife. Regarding the CASA, some physicians and people are with the CASA because really it's objective measure of sperm parameters. It really has an accurate motion assessment, and it also can give us a hint about hyperactivated motility, which is required for penetration of cumulates in zona pellucida, and it's the biomarker for the successful of human fertilization. However, this data are questioned by many other authors, and I need to tell you that the computer used in Egypt is not performing very well because most of the versions are coming. I think they are not optimal for such use. I have tested some of these machines I was not happy with, so I depend much more on the manual investigation. I'm quite confident in its value rather than automated system which are in our country. What is against this test is that they are very expensive and sophisticated instruments, difficult to learn. Any trained person, the person also need to have a constant visual supervision and calibration, and has to have a good knowledge of semen analysis. He cannot depend entirely upon the machine. And most importantly, there is a problem in identification and differentiation of spermatozoa from other objects, like round cells, cytoplasmic droplets, or debris. Many azoospermic patients come and see me with a report, with a count, and then when I check, it's a CASA system. So it's not accurate for azoospermic patient at all. Biochemical tests, zinc, carnitine, alpha-glucosidase that we used to do in the past are really not very important nowadays, and we don't depend upon it very much. Also, post-coital test is proved after being deemed as unnecessary. Now, frankly, the SRM told us in 2015, don't perform it anymore. Also, anti-sperm antibody is no more required as a routine testing, as cases are typically managed with the use of EFRE, and there is no effective medical treatment for such conditions. Now I need to speak about the less commonly used specialized test, which seems to be also important, but not frequently used, like reactive oxygen species measurement, acrosome reaction, human zona pellucida binding test, sperm penetration assay, and test and procedures that select sperm for ICSI. I mean by these tests, the hyaluronic acid binding, membrane motility tested, introduced by Huzar in 2007, the apoptic evaluation by magnetic activated cell sorting, the MAX, and the magnified sperm organelle microscopic examination, the mesome. And actually, all these tests need extensive study to better understand their predictive role in ICSI area. So till now, we are not sure. Still, all these tests are in the area of research nowadays. It's true that this test may offer greater predictive power than traditional semen analysis, but requires strict validation before recommending its use in clinical practice. And these tests were largely used before ART area, and now physicians are using it less. The reason it is because by X we bypass the evaluation of the male partner, and many feel and believe that these tests are irrelevant. So the question when to order a sperm function test, you need to order when you cannot predict the main fertility by semen analysis, like when you have a borderline parameters or when you have an unexplained infertility, especially in long history cases, because after 2-3 years, you cannot tell the patient anymore you are normal while he is not conceiving. And cases in which identification of the cause of male infertility will direct the treatment and history of ICSI or IVF failures. So, but keep in mind before prescribing any test, what does this test will measure? What are the indications for ordering this test? How are you going to interpret the results? And what are the therapeutic implications of the test results? And does this result change management of the couple? And can therapy improve test results? And does this improvement correlate with the higher pregnancy and delivery rate? Because this is the final aim of any test that we prescribe in for prognosis and for assessment. Lastly, I would like to thank you for inviting me, and thank Merck for inviting me and making this elegant symposium. And I'm inviting you to join us in our Facebook EFRE interest group of andrology again. Thank you very much.